I think everyone's been really, really helpful, and thank you for muting microphones on entry. That's great. We have 27 people in the room at the moment, so that's absolutely fine, and thank you. Wonderful. Okay. We're in, all sorted, and I think everything's settling. So I'm going to start, as we are now on 1851, and welcome to everybody. Thank you so much for joining today. I will introduce myself and I will introduce Natasha as well, just as a starting point. My name is Lona Johnson. I'm a consultant in public health. I work for Public Health Wales. I used to work for Cardiff University for dental public health, and I've been working in lots of areas of dentistry for a number of years. My job today has been to facilitate this workshop, and it really is very much focused on the CDS. And I will go through a little more detail of this in a moment. I'm also just going to introduce Natasha Hill, who should be here. And hello, Natasha. Natasha's joining us today. She's going to take some notes. She's also going to give me a kick at any point in time when she thinks other questions are needed for prompts. The purpose of this session really is to go through a number of things really much more focused on the CDS. We've had a pandemic. We've had a huge period of time where things have been very, very challenging. We're also going through a period of contract reform. And although the contract reform is more in the GDS than it is in the CDS, we actually have everything that all joins up. There's no point in the system where there isn't one part of the system that doesn't affect the other. And this is quite critical with an awful lot of what we do in terms of our patients, the care, and each part of the system is all joined up. And of course, contract reform will have an influence on the CDS. So my starting point really for this today, and I'm going to encourage everyone to use the chat and also put their hands up as they wish to speak and make points, because I'm more than happy. This really is an open forum. Some of the information we're going to be doing is at the moment, Natasha's going to be taking notes. I believe we're actually recording this. I hope everyone's happy for that. We're not doing that from a point of view of difficulty. We're really doing this as a point of view of really trying to capture what's going on in the CDS, what the concerns are, and what your ideas, your thoughts are moving forwards. Because we don't want this just to be about thinking about, yes, we've got these problems. We want to listen to what you've got to say. Tell us what's going on. Tell us what also your thoughts, your ideas. And this is really about the CDS and your patients. So I'm going to start at the beginning, and I hope this is really helpful by starting with quite an open one. And this probably is going to have 101 messages. And I will, and of course, if you do wish to say something, just put your hand up or put a message in the chat. Both is really helpful. And my first question really to everybody is to say, where are we? We've had the impact of COVID, but we had problems before we started. Where are we with the CDS? What are the main things that are your key issues at the moment? And what is and in terms of the pandemic, are the things that have been magnified or made worse? So it's a really open question to start with, and I would be very grateful to sort of open up the floor in terms of identifying the problems. And then I'd like to go into some of the contract reform elements as well, once we've just sort of surfaced some of these problems. So would anybody like to say anything about that? And if not, I've got a couple of people who I know I would probably invite to say something. Sandra, thank you. Do you want to say something? Do you want to unmute and say hello? Nope. Recruitment.
Really, from our point of view, it's just that as people are looking at their work-life balance, we're losing whole-time equivalents. Also, as well as that, it's harder to get posts for dental nurses that were easy to fill. Used to get far too many applicants for the actual post. Now they're coming in scarcely. They're sparse in numbers now. And I think that's just a recruitment problem overall. It's the same in GDS, but it is worrying, especially in our geographically disadvantaged areas, as you can imagine.
No, recruitment's something that has been raised a number of times, and actually retention as well, because a lot
Yeah.
of good staff are being lost to the system from what I've been hearing.
Yeah.
No, that's really, really helpful. Are there any other areas that have been, I mean, waiting lists and backlog and disadvantage for patients for things that might
Funding as well, Ilona.
funding? Yep.
Funding's also a problem. When you get crests year on year, you're getting a shrinking opportunity to expand your workforce
So,
at a time when you desperately need it, especially on the infrastructure side of things. If you want to do anything on the infrastructure, you have to lose clinical posts, which is absolutely ridiculous. It's counterproductive.
so the infrastructure in itself, you want to put investment into the infrastructure, but that is at the cost of staff.
Yeah.
Okay, that's really, really
When I say
helpful.
infrastructure, I mean support staff rather than premises, because that comes out of a different budget.
Yeah, that's helpful. Rahini, you've just put a point up as well, just about the funding.
Thanks, Elena. I'm just going to echo Sandra's point with funding, where I know it's probably the same with most of the health boards, where they have to do cost cuttings and CIPs and things like that, which then in turn affects workforce, and we have to retain the workforce that we have, but we can't recruit sometimes new posts or even replacement posts, where then it impacts on the existing workforce, where they're thinly stretched. And then we all know about the fatigue and the COVID impact that has on that has affected the workforce. So I know health boards are trying, and we have raised this, and they are trying their best, but it still is going to be a time impact, isn't it? How long is it? How long are we going to be able to sustain? And this then affects the patient care, because then the backlog, we can't address the backlog. We know that there is a backlog, but we don't have enough workforce to be able to deliver the service, even though we are almost back up and running full capacity, almost to pre-COVID. So yeah, that's it for me.
Thank you, Rahini. And Vicky, you've got your hand up.
Hi, everybody. It's really to echo what Sandra and Rahina have already said. But from our perspective, is that we were already struggling with waiting times, for example, for general anaesthetic in special care dentistry prior to the pandemic. And what's happened now is that we've got even longer and longer waiting times coming out of it. We are fighting with our medical colleagues to get GA space and the like, and it seems to me they who shout loudest might get that space. And so that's one of the biggest problems I think that we're going to have, is certainly fighting with our medical colleagues for stuff that's happening in hospital situations. But the other thing is that we've also got big long backlogs for our own patients. And the way that we've been trying to address it in an Iron Bevan is to start to do bite-sized chunks. So we cannot, address it all. So what we've decided to do is actually pick up certain areas, like for example, we have Flying Star Health visitor referrals. We've had further funding to try and look at that and see those patients at weekends with our dental therapists. Asylum seekers, we've had extra funding to try and to address our asylum seeker backlogs, and then also sedation. We've worked with primary care to take a number of our sedation patients off our hands into GDS that are only a sort of ASA 1s to 2s. And so, and this is the point, I think we have as CDSs got to work closer now with primary care than we've ever done. And I think, and I don't know how everybody else is feeling, is tonight I've got access to lots of general dental practitioners, the WhatsApp group, and they're really struggling. They're really struggling to know what to do about whether or not to take on that UDA contract or the contract reform. And they've got 3 weeks to do it in. and I can't help feeling that the CDSs may be having to pick up the fallout of this, whatever's going to be happening over the next couple of months. You know, we really don't know. So I think we're just going to be, you know, not only looking at our backlogs, but also trying to hold the fort of those patients perhaps who are not able to access any care at all. So it's a real big unknown, unfortunately.
So, I mean, I think you've made quite a lot of really useful points. One is obviously we've got the backlog of patients, and also the fact that actually if the service levels change in the GDS, the most vulnerable patients are probably going to be most at risk of being sort of falling out of the system. I think that's a really, really helpful point to make, and I think it is a real concern. I think it's something also that Larry Jones has just sort of put a comment of, which is really helpful, about the clarity about who the CDS serves and if you can't serve all and who should be prioritised and all of those. So it'd be really helpful if you'd like to speak, Larry.
Yeah, thank you. Just to follow on what Vicky Jones just said, exactly, there's only a certain number of us. People already mentioned staff shortages, and if there may be an increased demand, we might have to rationalise services, and how do we do that, and who makes those decisions? And there are, in my experience, some legacy patients, some patients who have chosen to stay on for various reasons, and then you have to make a choice between patients who are used to coming to their service, who might be okay in the GDS, but the GDS infrastructure doesn't exist for them, and just trying to shift that access appropriately, and just wondering whether there's a discussion around that alongside the GDS reform.
So the pressures in the system, that I think what I'm hearing is that the pressures in the system are likely to have an impact on the most vulnerable, and and there are real concerns about sort of the pressures actually hitting in the wrong places, and actually on quite a pressured workforce as it is, and a tired workforce. Also, I think Sandra's put a comment, and it's also reflected by Dominic Mason about, I'll come to Sandra's comment about a lack of specialists, a shortage of specialists. I'm assuming that's also by area, and certain areas are much more lacking in specialist support. Is that Sandra Sandham?
It's really to do with recruitment of specialists, because as somebody leaves, you can't actually replace them with a specialist. So the chances are you're going to have to go out for senior dental officer for band Bs with advanced skills. It's just it's a difficult area to look at. But there is a national shortage of specialists in special care dentistry and in paediatric dentistry as well.
And I think Dominic Mason's also put a comment about the existing workforce being quite thinly spread. So, and recruitment issues. Is there anything you want to add to that comment at all? It's not compulsory to speak, by the way.
No, I'd echo what Sandra said of it's hard to recruit, and those of us that are still on the ground are struggling to cover what we did before, as well as covering for the staff that have been lost.
Yeah, I mean, I'm going to ask a strange question. Does everyone feel it's quite difficult to deal with the backlog that's there? I think that's something I was just curious as to, because I'm feeling that what's coming through is there's a big backlog, and there's concern about an addition to that backlog, and then there's just more and more pressure in the system, and what there is there to deal with it just isn't enough there at the moment. Is that a fair reflection of that kind of space? That's really helpful. Thank you. I was going to sort of just quickly ask as well, is there an impact on any particular patient groups, or, you know, is it the vulnerable who are most at risk, or is it just across the board, or are there issues with prioritisation? It's just a sort of general question, I know, but it's just oh, Vicky.
Well, what we have found, and I suspect that all the community dentists on that will have recognised this, is that our medically compromised or immunocompromised patients, so those that are vulnerable, have been sent those vulnerable letters, you know, that they're clinically vulnerable letters, are the ones that are still very scared about coming out and seeing us. And as soon as we get an uptick of the transmission rates of COVID-19, all of a sudden they scurry back into their homes and are very reluctant to come out. The other thing that we've found, and I don't know whether everybody else would agree with this, is people have got out of the habit of coming to see us too. And so, we're also finding that that we're getting cancellations at the drop of a hat, often saying that they've got COVID inverted commas symptoms, but we're never really quite sure whether that's actually true, or the carer's got it, or somebody else has got it. And so, therefore, I think we've got a lot of building to do in terms of getting them to be comfortable about coming back to our surgeries and knowing that they'll be safe when they arrive. So I wonder if everybody else feels the same about that.
So do you think there's a communication piece that, oh, sorry, Rahini? Oh, I was just, yeah. So I think I was just going to, Rahini just put in a comment about prioritising vulnerable patients and being very challenging. I mean, do you think there's a communications piece with patients, or, I mean, it was hard enough to get half of the population to come to the dentist in the first place. And the most vulnerable, if I remember the statistics from when we did some of the work on the CDS many years ago, it was actually the most unwell and most disadvantaged found it hardest to get to the dentist in the first place. So if you had hearing problems and sight problems, your likelihood of going to the dentist was quite significantly decreased compared to everyone else's. Michael, you've got your hand up.
Yeah, hi everyone, and thanks for the opportunity to participate. Just on that point, like Vicky's focusing on a very worthy group. It's also this issue of the wider context of focusing on inequalities on the sort of ground vision, is that you also can have the situation where it's this things don't often synchronize. Inequalities and the most vulnerable patients don't always synchronize. We have a situation where you might have some very well spoken for groups who are vulnerable patients, but yet the biggest area of need may be in the actual districts themselves, and it's not necessarily a very easy win. You may have very sort of like, again, don't get me in the wrong context here, but talking about people with the loudest voices, and you may have people who are in a vulnerable group but may have very good assets and resources, but yet you have people who are actually suffering from a lot of inequalities who don't qualify as a vulnerable group. And this is a huge challenge that you have, as Laurie's mentioned. Where does our remit come into in the end of the day? And making those choices on an individual patient are very difficult. You know, there's no heroes or villains there. I just thought it was worth mentioning that.
No, it's a really helpful comment. And it's one of those things, I think that Sandra said, there's difficulties in accommodating patients with challenging behaviours who need GAs during COVID and they're noticing very much deteriorating oral health amongst the groups. Prioritization's a challenge, and I think that's something that's really coming through with the comments, just, you know, with your comments, and actually just understanding. I think what I'm hearing is a lot of concerns about the patients and the quiet groups who disappear in the mix, for whom we don't have much data, who don't really get seen, and we don't always know who gets seen, when and where. I'm going to ask a strange question about the GDS reform program in terms of, because obviously there are some patients who could be seen partly by special care, partly by the, you know, or there can be kind of a shared space within, or some patients who may not need to be seen by the CDS who could be seen in general practice if it was able and had the capacity to accommodate those patients so that the CDS was optimized in its function. Sorry, I'm going to say this, I'm trying to put it in the most clear way possible. Are there any thoughts on that kind of, is there a way of making that a little bit better, or do you think it's impossible to reach that space? Lowry, I think you've got your hand up then, Vicky.
Thank you. Yes, I just want to comment on that. It comes back a little bit to what I've mentioned already. If the GDS capacity is there, the patients who are currently sort of choosing to stay with CDS, and it's a very difficult thing to sort of kick them out because they have nowhere to go. If the capacity was there, we would feel much more confident in passing them on to a GDS colleague who is likely to be able to handle them at their current level and just dip into us as and when needed. But it's a very hard thing to do, a very cold-hearted thing to do when the whole geographical area is vulnerable in access. This was a problem I was having. The whole area for about 20 miles in each direction had no access, and people were trying to use access as a way to get in, but I was having to prioritise in other ways because everyone was vulnerable in access.
Vicky, thank you so much, Larry. That's really helpful. Vicky, do you want to add to that point?
I absolutely agree with Laurie about the fact that you know, and our staff struggle with it as well. Actually, Ilona, is I had a meeting with our staff the other day, and our dental therapists who were trying, and I was talking about offloading patients in order for us to try and reduce our backlog, and they were saying, but to where? We, you know, there weren't any dentists taking on. Dentists were refusing a massive. You know, I've got one of our practices got 3,000 patients waiting to be seen in one of our GDS CDS practices. So the point is that we would love to have robust care pathways from the CDS to the GDS, but there just isn't that capacity out there. The other thing that we've been doing, and as you know, Ilona, because you're on the South East Wales Special Care Dentistry sort of MCN, is that we've been trying to develop over the years care pathways whereby, you know, in anticipation, if it did go to contract reform, that we would have care pathways in place where we'd be working with our partners, you know, GPs and with other healthcare or social care, whereby we could be identifying vulnerable adults that wouldn't ordinarily be seeing general dental practitioners or the CDS, and having something in place whereby they would be identified and triaged and go to the right sort of place, and that we would be supporting practices in training and the like, and so that they could accept them, for example, dementia, diabetes, all sorts of things. And you know, I know this is a future vision, but we always thought that might work. But at the moment, from what we're seeing, we can't see this sort of thing happening for a number of years because of the huge number of patients that really can't find access to dentistry. So, but the other thing is about the CDSs having very robust acceptance criteria and also discharge criteria. And if we got a very robust ones that we can only let in those that really do need to see us, that would help. But the trouble is we're all humans, and we really feel sorry for patients who are trying to hang on and they can't go anywhere. And so it's difficult for us. It really, you know, and plays on our heartstrings, and isn't value for money. It isn't very good for the health boards. But what else do we do?
Thank you so much. That's really helpful. So it's really about, you've got patients who potentially could go elsewhere, you know, go into the GDS, but they can't because it's not the space and the capacity, and it just isn't there for them to do it. And at the moment, the system doesn't look like it's, with what you can see, it's not in a state of readiness to do that change. Rahina, you've got your hand up, and then Michael after.
Thanks, Ilona. Yes, to add to Vicky's points and Laurie's points, there isn't access, plus the fact that GDPs obviously work under a certain contract. So even if there was access, do they have enough time to spend with these patients who are vulnerable and who require, you know, who have additional complexities, whether it's physical, medical, or mental, you know, issues. But they then would need to be having that sort of flexibility within their contract to be able to spend that little extra time to cater to these patients. And also in the long run, I mean, this is not short term, but also some sort of training to be able to manage these patients within their practice, even if they can't do it extensively, but to an extent which is not as complex as what we would deal with in CDS. So there are 2-3 points over here that we would need to address before we can actually send those patients to a practice that we know will be able to cater to those patients. And like Vicky said, when we know that we can't send them away, knowing fully well that they don't have access or they don't have the time to be able to cater to these patients, plus they don't have enough training, then it's just unfair to just offload them because they don't technically fit into the CDS remit.
Because they'll just get worse anyway if you leave them.
And they'll come back to us with a worse off problem.
Yeah.
We may as well keep them. And it's the same with both adults and children. We see that all the time. And in the midst of all this, we must remember that there's a patient being passed from pillar to post. So.
And the most vulnerable ones fall out in that process as well. So no, that's really, really helpful. Michael, you have your hand up.
Oh yeah, thanks. It was just to make the point I just put in the chat. As long as we have, variation in acceptance and discharge criteria, which obviously is a good thing too at the moment because it allows people to make at least the best possible decisions. It's so difficult across the health boards if there isn't a standardized framework. I mean, we're talking about a national policy here. We're talking about a national strategy for the GDS. We're talking about a national strategy for health and well-being, but a well-informed patient can challenge you and say, well, you don't have a national strategy for what the CDS does and what its acceptance and discharge criteria is. And we're a small country, a small patch. It's possibly not the most challenging to decide what that could be. And that's also about messaging as well. It's about being upfront with people and saying, this is what we can do and this is what we can't do. And with all respect to people mentioning, not individuals, but just to the concept of going back to pre-pandemic activity, not that the pandemic is the big sort of thing here, but we should be very cautious about going back to the same old too, because we were in problems here before the pandemic. And it's really important that the CDS discharge criteria was something we were working on before 2020 and as is everybody, and just probably worth bearing in mind that I think unless we can give patients a consistent message, and I do also hear people talking about offloading patients, and again, I'm with all my colleagues on this. I'm not trying to be anything sort of provocative about it, but patients don't disappear and they can come back and they can access primary care in other ways close to us, and we can keep an eye on them. And the difficulty is that people get attached to a place, and we don't want them to go because of personal relationships. But we also have to think the whole concept here coming through the contract reform is about inequality, and there's patients out there we haven't met as well that we need to think of, and who are potentially in worse positions because we haven't got there yet, or they're on the back of our waiting lists. Sorry, that's a little bit of an extra rant there.
No, it's really helpful to I mean, that's the point of today, is to really listen and to try and surface a lot of the key points. I mean, I certainly back, I'm going to go a long way back now, back in 2010, we used to have a national group, and there used to be there was a discussion, and we did a workforce review, we did a national group relating to special care dentistry, and then we had the MCNs and they met, and then we haven't really had as much, I was going to say, that kind of national centralization of sort of joined upness in the same way that we did within the CDS and the special care dentistry spaces that we did. And I don't know if Vicky wants to come in with this, and those opportunities to try and make sure that we have sort of equitable standards in each area. And I suppose the other point I was going to, and I suppose I'm just sort of putting a challenging question out there really, is about, do you think you've had enough opportunity to influence the GDS reform program, or put that kind of balance of equitable in that space? So in other words, have you been able to kind of have that space to kind of talk into? Yep, absolutely not. Yep. Yep, sorry, I've missed some of the, sorry, apologies. Is there an intention to introduce patient charges aligned with the GDS? And no, I think Larry and Vicky, do you want to surface the conversation?
Sorry, I know that's not what you were talking about, but I'll just explain very briefly a couple of comments before you brought this point up. I work in GDS and CDS, and not all patients would have to pay because of the fact that there are exemptions to payments. And I was just wondering, is there a conversation around that? Because what we are seeing in certain cohorts of patients who are with the CDS, who are phobics, who are not having to pay, and who could be managed non-medically for their phobia. It's just this kind of difficulty in getting them back to the GDS because they find they get a service they don't have to pay for. And it's very complicated and multifaceted, and I'm aware of that. I'm just wondering.
No, I think it's really useful. I think Dominic's put a comment in about the skills in the CDS, and also Sandra's put some comments about the infrastructure in the skills in the GDS, And Sandra's mentioned the infrastructure in the GDS as well, and those spaces. Dominic, do you want to come in on the thoughts on education?
Only based on some of the things that have come out in North Wales from directorate level, etc., of perceived gaps in knowledge or skill or confidence, and how we can help to improve those. And I think if we're going to look at some of our patients being triaged back out into the GDS when there's capacity, you know, I think we sometimes forget just how talented and skilled a lot of our therapists and dentists are at treating people, and what we see as routine isn't so routine for others. So maybe we need to look at improving that level of confidence and the ability and knowledge and skills within the GDS to feel empowered to be able to tackle these cases.
That's really, really helpful. So there's a bit about the financial side of the barriers, the educational side of the barriers, so, and also the ability to move people, I suppose, fluidly between the GDS and CDS in a way that is optimizing the skills and services that we do have, and that's not quite there at the moment. Is that the kind of messaging? Have I missed anything in that space? That's really, really helpful. Michael, you still got your hand up. Did you want to come in?
Sorry, no, I think I have been slow in taking it down. My apologies.
That's okay. It's not a problem at all. That's fantastic. So that's really, really helpful. And I was just interested in terms of, because I think we've identified a lot of the problems. I'm going to ask a slight, I'm going to flip the questions around a little bit. It's about moving forwards. What, and this is just a very open question, because I think we've got some of the challenges. I'll firstly ask, do you think there are other challenges that we haven't identified? And please, if there's anybody who's working on the ground who thinks there's other things we've missed, I'd be really interested in hearing what. So you don't have to, if you don't want to say anything, I'm more than happy for you to just put a message in the chat. You've not been invited to participate in the GDS. I thought that was the case. So that's a useful thing to consider in terms of, would it have helped, or would it help to have the ability to have a voice in that space? And oh, lots of chat now. And Michael and Sandra, do you want to come in, because there's a couple of points you've made, and then I'll come to Catherine.
I just keep I just keep typing in, so you better tell me which one you want me to talk about.
You said you weren't invited to participate in the GDS, and
I mean, I was personally, because of the position I held, but generally the CDS wasn't invited to a lot of the early meetings that were held that involved just GDS.
do you think the CDS have enough of a voice in that space to help shape that communication between the two?
Probably not. I don't think it was helped in the early days, in that there was a lot with HEIW that CDS was excluded from as well. But yeah. That's history. I think that's improved.
Yeah, and I think there's a comment from Catherine about sort of cases for sort of further development in terms of tier 2s. Did you want to come in, Catherine?
Yeah, it was just an observation, basically, what Dominic was saying about, we do take our skills and abilities for granted, and he's absolutely right. Just do stuff, but actually, in general practice, they can't just do stuff. And I think perhaps we look at this. We're talking about the cases of developing, tier 2 surgery in the general dental service, where things can be commissioned there. We're talking about tier 2 restorative type things where stuff doesn't have to go into the hospital or in the special services. It can be commissioned outside. So maybe there could be a case for developing the skill sets, having your dentist with enhanced skills, or level 2 tier 2 skill sets within the general dental service. And that might be something to be thinking about, whether health boards want to be looking at that.
No, that's a really, really helpful comment. And it was one of the things I've discussions we've had with Vicky and Grace and a couple of the specialists about, because at the moment the ACORN doesn't really include the, and some of the research we've done in the past looked at what was needed to treat patients in the GDS. And a lot of them just needed a lot of extra time. And so sometimes they just needed time, and there's certain things that they needed, but at the moment, a lot of the data that we have doesn't really tell us what they need. So our data doesn't help inform that build either, which would be quite helpful. It's just something, I suppose that's coming as a point from me, but it's just we were trying to find a way of, because obviously you had the case mix tools to identify the levels of need, but we'd created a simplified version of that to say, how many of your patient, does this patient have an additional need, and what level of additional need, and is it something that could be seen in the GDS if it just had, and it is if they just had, is that kind of build space. Sandra, yeah, tier 2 currently being discussed in the GDS and CDS, and I think that is a space that's really important. I don't, at the moment though, we're so pressured. I think it is a really important one about how we move this forwards, but I think it would be really useful to, as you say, tier 2 skills. Do you think the GDS, I'm going to ask another question, is not only about the tier 2 skill, but also that kind of movement between GDS and CDS? Do you think the GDS understand it well enough or use it well enough?
I think the shared treatment, the shared treatment pathways is the way we're going to end up going, and we're already doing a bit of it, but that's with the converted practices. The practices that are engaged, probably a lot of work to do with those that aren't engaging.
That's a really, really helpful comment. Thank you so much, Sandra. Oh, Michael, sorry.
Yeah, it was just there to say it's this thing of, as well, comes into your head of the community dental service, even in its best incarnation, it sort of sits on a fence where 1 minute it faces into primary care and it should be thinking in primary care terms, and then in the next breath, it's this in terms of treatment service, at least. In the next breath, we're accepting referrals, we're having to manage somebody akin to maybe somebody taking a medical specialist taking a referral, whatever the reasons that behind generating that referral. And that's a difficult balancing act, isn't it? And I know it's not a new one, and it's no one that's all it's not news to everybody here, but again, it's quite crucial going forward, because these are the sort of, to me, that these are some of the crunch points that are going to come to a head as GDS reform goes on. People will challenge what the service is meant to be doing, what it's for, and if it's not sort of up to maybe at least some core sort of needs, then it's in the way, basically. It could be, that's a little bit of blunt speaking as well, because it could be that it's simply that everybody wants it to do well, but it doesn't have the resource or the stuffing, and therefore some alternative has to be found, some alternative model, because of public pressure and political pressure.
That makes a lot of sense. Do you think we've defined, and this is coming back to a point that you made earlier, is do you think we have well enough defined what the CDS is and isn't?
It's only my personal view, and I wouldn't say I'm totally sort of on top of the game at the moment, but I would think it's probably at least due a decent conversation whereby we can at least, if it is agreed, I think it should be highlighted, and that message needs to be consistent. It can't be everything. The GDS can't be everything. The NHS can't be everything. And we're now sort of straying into this more political side of things, where we have to say to people, like we do say to our patients, we do limit what we can give them. We are sort of good at saying to people, this is not what we do in certain areas. But it's important to make that message consistent and to be applied. It's difficult enough to apply it from a clinic to a clinic within a given health board, never mind across health board to health board.
That makes an awful lot of sense. Do you think, is there anything, and I think that's really helpful. I'm going to ask a question, and this, I suppose I have a purpose behind my question. Are there enough conversation spaces for the CDS, to be able to basically, have that national plan, have that national strategy? Is anything in place enough to do that, or are there certain work streams that we need to consider? Everyone's nodding and thinking. I mean, for example, we did have, a special care dentistry national group. We do have a national group for the, if I remember correctly, that we certainly had for the older people. We had the NAG. So which I know it always sounds like the terrible name for older people's dental care is the NAG. But we did have those sorts of national groups, and there was a space for discussion. And years ago, there was this special care dentistry advisory group, which did have GDS representation, and that disappeared and just hasn't sort of reformed and come back. And that did include discussions about the different areas. And do we think that something like that would be useful and needed, or are the MCNs functioning well enough to join in, or does the CDS need something to, in terms of, you know, moving forwards, is something else needed, as I would probably put it? I'm being probably a bit high level here, and I'll come on to on the ground in a moment.
I just chip in to think that all the activity for the MCNs, for example, and pathways, it's incredibly worthwhile work. The danger is that the technicalities of it you can sometimes lose, and this is my own personal view of how I function, is that you can sometimes lose the overall sort of goal. And it can start to get very treatment focused again, and you sort of lose track of where the strategy is, what the service is, what the mission is, as opposed to the current course ahead, you know.
That's really, really helpful. And in terms of sort of moving forwards, and I suppose it is about sort of coming up with sort of things which relate to because they have the GDS reform programme. Do we need to do something from the CDS that kind of joins into that process? Because they've given you a structure, they've given you the pictures. Is something more needed to help? Is it that you need to be involved in the groups? Is it that there needs to be a communication? Is there something that needs to happen? Vicky Jones has disappeared and come back. That's fine. And Sandra, it says you think the lead. Yep, Sandra.
Yeah, I was putting something else in then.
It's all right.
I lost the train of thought. You mean on groups?
Yeah, groups is good. And you mentioned about secondary care and cancer.
Yeah, I was just saying that the secondary care, from the point of view of how much we do with secondary care, seems to be underestimated. I think there's a lot of what we're doing as a CDS and what we can do with practice, but what we can do with secondary care, or what we're already doing with secondary care, seems to get lost in the mix somehow. We're very much a complementary service. We're very much the service that fills the gaps, but the big gaps are getting bigger, and it's harder to fill than it used to be.
Yeah, I think the thing that's coming through more than anything else is the pressure on the system and the ability to deliver, and the fact that actually the patients have got nowhere else to go is coming through. Rahini, sorry.
Elena, I'm not going to repeat everything that we've said before in terms of limitations within the CDS and everything, but for you to be able to get an idea of how much work CDS are doing and the type of cases and everything, FP17s obviously is not the best data collection form for CDS, and if they can revise that and start that as make that as a starting point, then at least you'll have a good database of what to work from.
So really, that's exactly what I've just started typing.
Great minds think alike.
Yeah.
I'm sure everyone will echo that, because we are not capturing enough data from CDS activity.
We're not capturing the referral sources either.
No, and I'm wondering whether there's enough data about special care need in the GDS to actually help identify where things are actually being. So it was something we identified back in 2000, and the report published in 2010, we identified that the data sources didn't tell us enough about the special care patients and where they were being seen, and to see where our gaps were in terms of who wasn't being seen. Larry.
Hi, yes, just to come back to your point about could we learn or implement anything from the contract reform process. I think GDPs in general understand or have a drive to provide data because it has a direct impact on their income. I think better understanding and communication with the CDS cohorts about what our data does would be a great motivator for us to actually generate data submit in a timely manner, make sure the data is complete as much as possible. I think when we don't see where it goes or what it does, that motivation is very difficult. And just to follow on the point I've made earlier about in line with the GDS reform, I think that it is an opportunity that where patients who are not exempt, I feel it may be an opportunity to review the conversation about charges, but we've covered that.
No, I mean, I think the conversation about charges is an important one for disadvantaged groups. Oh, Vicky.
Hi, sorry, I fell out. I mean, in terms of, we were just talking about the use of FP17W. I think we've got short memories about the reason why we had to go to FP17W in the first place. Is because each of our health boards struggled. Well, I think some health boards struggled to be able to produce the data that was necessary for Welsh Government. So I think if we're going to drop the FP17, then we must make sure that we have in place within our health boards the opportunity to be able to produce the data that Welsh Government want. And I know, and I can remember, a number of health boards weren't able to be able to produce that data for Welsh Government, and that's why we had to go to FP17W. And I absolutely agree with everybody. It does not give any indication of the types of patients or work we do or the referrals we get from to be able to look at service planning for the CDS. And also the other thing is that with the FDS referral system, I would say that we get 2/3 of our referrals from non-dentists than we do from actual dentists. So when they talk about, well, let's look at the referrals that you get from the general dental practitioners, that really isn't an indication, and I'm sure it's the same with the other services, is an indication of the referral pet care pathways we got. So we record those manually of all those referrals coming into us from a central base so that we can show the types of patients that we're actually seeing.
So the information that you've got, that you're collecting, you don't feel is quite fit enough for purpose for reflecting what you do, and also for planning ahead for the patients that you have. Is that an accurate description? And we need to have a look at data. I mean, you're doing Acorn as well, if I'm not mistaken.
Yeah.
So and how do you find is the Acorn useful, or should there be something more?
Well, the Acorn is fine. I mean, we did the pilot up in North Wales and in Iron Bevan when it first came out. We did indicate at the time, Sandra and myself, that the actual Acorn doesn't really fit with the sorts of patients that we see. A lot of the questions about siblings or the ability to carry out care. So it would be useful to us if we had a modified version that actually reflected the special care patients, for example, or the vulnerable patients that we see. But we realised that would be too difficult. But I quite like the Acorn because I think it actually indicates it's actually a process. And it actually makes sure that everybody's delivering better oral health and the preventive side of what we should be doing. Even if we can't do a BPE or something like that for patients, it structures, it makes sure that everybody's getting what they should do in terms of prevention.
That's really, really helpful. And actually that preventative side of, there is a support for the preventative side of dentistry, obviously coming from public health. I'm really pleased by this. But no, that's really helpful. And there's a comment in here by Jess Bell Davis, and I don't know if you want to speak to this or not. It's not compulsory, as I've said, about secondary care tends to automatically refer to the CDS, even if they could be seen in the GDS. So there's something about the operational workings of how everything all pulls together, that kind of default system. And it comes back to, I think, the point that Larry was making about the GDS. No, trying to get a 4-year-old to sleep. No, yeah, I remember that well. 4-month-old to sleep. Yes, no worry. To be honest, thank you for typing in the comment. We're very grateful. But it is true that actually it does come back to the point that Larry was making earlier about the those mechanisms and that space and being able to utilize the GDS effectively. And at the moment, it doesn't. It's just, it might be working in certain areas, but it's not working uniformly. Would that be fair? And there's huge capacity issues. That's really, really helpful. So I suppose we've got about, I think, 10 minutes. Yeah, there we go. We've got 10 minutes left of this breakout session. I see that was almost psychic. It was really quite organised for a change, or maybe it's just the clock was there. We've got about 10 minutes left in this space, and I think it would be really helpful if there's, first of all, if there's any other points that people would like to raise for a point of actual discussion. This is a really helpful place to do that. So if there's any points that people wish to raise, that would be helpful. And the other point I was going to sort of make from this was about moving forwards in terms of if there was, I suppose, that wish list. If there was a I always like a good, it's kind of getting some agreement on the wish list. What is it that you most want to see? You see this, I know it's a challenging question, but I would like to, what is it? What's your vision? What would, if we're going to have a plan, a vision, something moving forwards that includes a CDS, let's be ambitious. What's our vision? Everyone's gone quiet. Okay.
I think, just again off the top of my head, and that's not the best place, but I think I put a question in the pre-meeting chat, was to where does this strategy in terms of the GDS reform, where is there somewhere in the documents, is there somewhere in the meetings even a fair vision of what the impact is on the sort of the gap of the service that the CDS tries to sort of fill, and where people might be sort of seeing that. I mean, I know, as what Warren said, there's going to be lots of areas that people have to see what happens. And is it a case of really we have to wait and see in the CDS? I don't mean wait, do nothing, but like fundamentally in terms of its long-term future, worry about what the sort of response to the GDS reforms is and how it affects practices, how it affects individual practices, decisions, and then the CDS is the instrument by which at least there is some, at least basic response to deficits and gaps in services and provisions. That's a big one. So it is a wish list. Yeah, sorry about that.
No, we like this. This is the point. It's ironically, everyone's come up with, we want something clear, we want something shared, we want this to feel joined up. That's what it's really feeling like, and we want consistent messaging, we want consistent communications. Vicky, do you want to come in?
I'm sorry, I'm talking too much. I know I am, but you know what? I can't help feeling that the issues for us in the community dental service would be, a lot of it would be relieved if they sorted out access in the GDS. So if they really could sort out the access in the GDS, it would mean that we would have more opportunities to be able to identify those vulnerable patients that we should be seeing within the CDS. And it would help us. The other issue, and we alluded to this before, was about having the right proportion of specialists. Now, obviously I'd say I'm a consultant in special care dentistry, is that, I like specialists, but we also need those generalists, and certainly within our CDSs, we'd need that. But skill mix is the way forward, in my opinion. I know there's a number of our CDSs that have got quite a number of therapists and hygienists, and our dental nurses, I know, are all being trained. But I am really with Kirsty when she was actually presenting that. Is I think that if they start to train these patients, that we can start to have really good, robust teams that are in place for us to be able to have that fantastic care pathway. So that would be my vision for the future.
That's really, really helpful. Thank you so much, Vicky. Dominic, I think you've put a comment in here about better integration.
Yeah, as we've all sort of agreed, if CDS, GDS, secondary care can all integrate, those patients can be shared and directed to the most appropriate setting to sort of make us all more efficient in that sense. But maybe like a wider, not just GDS reform, but CDS reform. Can we not have a national conversation about how we move ahead as united CDS fronts across Wales?
It does, it does feel like there is a sense of join up. Single record. I'm going to come back. I'm going to go to, I'm going to just lift a couple of comments from Athena. We'll find out where the easiest place to find that document is, because it's clearly the communication hasn't come to you. I'd like to see, and Dee has said, I'd like GDS to see patients who do not need CDS so we can use our workforce better. And I think that's in reflection. If you want to add any comment to that, Dee, let me know. But I think that supports what Dominic's just said. And I think, Peter, you've just come in about a single record.
Yeah. We spend a lot of time trying to work out what the patients had done in the past in general practice, and we get the patient's point of view and maybe a brief note from the GDP on the referral letter, but we don't know the true story. And if we had access to that information, I think it would make our lives a lot easier. It would also encourage better shared care, as they can see what we've done, we can see what they've done in lots of detail, not just a little note on a letter. It's obviously a big wish, and one for the long term, but yeah, that would be top of my wish list.
But there is that thing about strategic planning for better care, isn't there? And that kind of space, I think that would be really helpful. So that kind of planning ahead of where we would like to be. Larry.
Just a quick response to Peter. My concern with that is that we might push GDS dentists away from NHS dentistry if that choice of software and those kind of things went out the window. That's the only thing.
But it's really useful. Now, I think we've only got about 3 minutes. So, Michael, if you want to come in, and if there's any other closing points in a moment, please let me know.
Yeah, I mean, that's great. Thank you very much again. I just think as well, as you know, to echo Vicky's point on skill mix, this becomes more of a managed thing. And if you look at some of the way the general medical services in Wales have gone over the last few years, where you have a sort of a move, and not a bad one as such, pandemic issues allowing, whereby you have gone from independent contractors to more managed and salaried services. And the more the government and, as a community, we want things to improve, we may have to address that fact that really, I suppose, longer term, we would like to see more, what's the word, convergence between what the CDS does and what the GDS does, because fundamentally, I think even GDPs would accept that as long as you have lots of practitioners who are still independent practitioners in principle, that if the current move of this reform is to sort of start to bring people into the tent a bit, where, I'm not arguing for some sort of huge, massive public dental service, but really speaking, we're all in the same territory here, and hopefully there would be still a market as in a proper economy for, affordable, private, independent dental care. But the fundamentals of the NHS dentistry here, which is what we're talking about, is it's really a bit of a convergence and a getting into bed really between a GDS and what the CDS does, as opposed to this sort of maybe permanent barrier, if that's the right word, between it. But thanks again. I think I've spoken a lot.
Catherine, do you want to come in? You've put a couple of points in there. We've only got about 2 minutes left, but.
Yeah, I'm not sure my second point went in the right place, but I was trying to reply to Dee about, GDS seeing patients that don't need to come to the CDS. And I think historically there's been a lot of the GDS have not been rewarded or encouraged through the current contracts really to keep them on, and that's why they don't see them, and they're not encouraged to take those on with the highest need or take on new patients, and hopefully the new contract will address that. And another thing I'd like to see is that we properly integrated in the CDS into the whole NHS electronic system, by being able to do electronic prescribing instead of having to send faxes to pharmacies, being able to find patients' HS numbers on the national system, being able to check that we've got their current addresses and whether a patient's has died. We can't even access that information from the national systems, and that would be a really good thing to see going forward.
That's really, really helpful, and thank you so much. So I think, summing up, I think there's a number of areas of work stream, some moving forwards generally, overall, but actually having a joined up strategy, that skill mix, all of the things that actually all point in the same direction is where where everyone wants to go. And I think the main concerns are around with the GDS is that people falling out, that basically that kind of sense of priority. If the GDS isn't seeing the patients, then the CDS will, but that's going to have an impact on where things go. So that's really helpful. Thank you so much for your contributions today. Really, really constructive. And I believe we need to go back to the other room. So thank you so much.